So good afternoon, everybody, and welcome to Neurology Grand Rounds. This is our third CPC of the year, and today's case is a child neurology case going to be presented by our graduating child neurology residents, Jason Lockrow and John Carter. So I'll give you a brief background. Jason is South Carolinian, although I've never, at least not yet, heard him throw out a y'all, but he probably does on occasion. So he did his undergraduate work at the University of South Carolina and went to medical school in South Carolina before he came to the Northwest. And we're lucky to have him around for another year as an epilepsy fellow. John Carter is originally from Michigan. He went to Johns Hopkins for his undergraduate and then did his medical education at Stanford before joining our program. And I was lucky enough to work quite a bit with both of them in the VA clinics. And for a pediatrician, it's got to be a little foreign being at the VA. But they never, well, I guess in both cases, a lot of the history is dependent on the accompanying woman. But they never seemed out of their element. They were very efficient and managing complex medical histories, med lists 30 long. So I really appreciate all the hard work they did on the adult neurology side, and I'm excited for them that they're graduating. And they're going to be presenting a case with Dr. Jim Owens today, and they're going to provide a brief intro for Dr. Owens. Thanks, guys.
So thanks very much for having us, and we really appreciate Dr. Owens being here with us. Dr. Owens is the program director and director of neurology education for our residency program here. Sure. We'll just stand very close. Dr. Owens is an associate professor in the departments of neurology and, by courtesy, pediatrics. Here, he's an epileptologist by training, did his undergraduate work in Spokane, and then returned here for medical school and for his graduate work, obtaining a PhD in biophysics, something like that. And then went off to Baylor, where he completed his residencies as well as a fellowship in epilepsy, as well as a postdoctoral research fellowship in disorders of cortical malformation. He also stayed on there as a faculty member, served as the director of medical student education there prior to joining the faculty here and taking over as program director shortly thereafter. So we wanted to present to you today what we've entitled a case of mistaken malformation or maturation, being focal cortical dysplasia. Those of you present for the last hour will recognize some of the basic concepts here. The objectives for this talk, first of all, are to understand the significance of focal cortical dysplasias, particularly as that pertains to epilepsy. Secondarily, to do a little bit of review specifically about the classification of the pathology of cortical dysplasias. Thirdly, to discuss a representative case who crossed our clinic and our ER much more frequently than we'd like to admit, although he's doing a lot better now. And then lastly, to discuss some of the current theories about the idiopathogenesis, as well as some options about treatment, both novel and not so novel. So what are cortical dysplasias and why do they matter? So broadly speaking, they are malformations of cortical development and fall into a much larger category, but have a fairly wide array of histopathologic findings associated with them. They're important because clinically they account for a substantial number of cases of epilepsy, particularly those cases that prove to be medically refractory. And to those of us both in pediatric and adult neurology, these are people who we are seeing, getting phone calls about, et cetera, on a very frequent basis. And depending on which estimate you read, somewhere in the avenue of 30 all the way up to 50% actually of cases of intractable pediatric epilepsy may be related to focal cortical dysplasias of one type or another, and the estimates vary somewhere in the 20% or so range for adult cases. There are probably slight differences in terms of actually which dysplasias we're dealing with. That very likely has impacts on outcomes as well, but by and large, FCDs as a group account for a very substantial proportion of these patients with epilepsy. Typically, the major clinical manifestation is epilepsy, and usually only epilepsy. Occasionally, there are other behavioral and cognitive issues that can go along with these conditions, and that obviously is in stark contrast with other malformations of cortical development. That being said, if seizure control is suboptimal, if there are other secondary malformations, i.e. if there's dual pathology, then we're dealing with an entirely different scenario. And importantly, the epilepsy tends to be quite refractory, as we've mentioned. However, these people tend to have relatively, and in an absolute sense, pretty good outcomes from a surgical standpoint, and therefore represent a very interesting population from both a workup and a management standpoint. You can see here from our slide, this is a conglomerate data from two of the largest studies, surgical series of patients with focal cortical dysplasia, and the success rate, and this is epilepsy cure, by the way, so seizure freedom, is somewhere in the region of 50 to 60%. So if we can appropriately identify patients and appropriately treat them, in this case appropriately surgerize them, then the outcomes can be quite good. However, the main determinant of that outcome is the completeness of the surgical resection, and as we'll talk about how to identify good candidates, how to identify in an individual candidate how we're going to get a complete surgical resection represents an area of significant and ongoing challenge, and we'll talk about some of the ways that we can at least try and improve that process. Despite all of what we know, there's still, as in most of neurology, a great deal that we don't know. And there are still major uncertainties as well as controversies, actually, in this field, including things as basic as how do we classify these dysplasias. A very brief bit on the history. They were originally described, at least in detail, 40-odd years ago by an Englishman working in London in 1971. G.C. Taylor, who described in a case series of 10 individuals 3 primary findings. These were, and we'll talk about these in great detail later, cortical disorganization, these sort of bizarre neurons, as well as a specific and particularly interesting cell type known as the balloon cell. Since that time, there have been numerous revisions to what exactly is a focal cortical dysplasia, what is a type 1, a type 2, what is, now that there is such a thing, a type 3, so on and so forth. And very recently, those criteria have undergone revision again. Much of that is due to advances in neuroimaging that allows us to identify these patients prior to going under the knife, but also providing us with more surgical tissue to then analyze pathologically. Some of this depends on advances in EEG and combinant technologies, including PET with EEG, PET and co-localized MRI, so on and so forth. But it's a centrally important question because not only are we trying to categorize what these things look like histopathologically, but there's every reason to expect from convergent lines of evidence, which we'll talk about, that it makes a big difference in terms of your outcome, what type of cortical dysplasia we're dealing with. Not only in terms of how amenable to resection you may be, but how those resection outcomes are. And despite all our advances in neuroimaging, pathology still remains, as it is in so many things, the gold standard for determining what type of dysplasia we're dealing with.
So then going a little bit more into the classification and pathology of cortical dysplasias and fitting within the larger group of malformations of cortical development, as John had mentioned, these have undergone a lot of revisions, but the most recent classification scheme was by Barkovich in 2012, where he tried to organize them based on the actual etiology of the malformation. So this is either pertains to abnormality in the neuronal and glial proliferation, abnormality in how those neurons migrate, or some sort of post-migrational injury. And so with group 1, you can have an increase or decrease in neuronal glial proliferation. If you have too little proliferation, you get microcephaly. Too much proliferation, you get megalencephaly. Or if it's somewhat focal in it, the proliferative disorder, you can have tuberous sclerosis with cortical tubers, or you can have focal cortical dysplasia. In group 2, which is abnormal neuronal migration, the neurons cannot reach the gray matter and they're stuck in the white matter. That would be the gray matter heterotopia. You can also have much more global abnormalities in migration with double cortex, lissencephaly, or cobblestone malformations, such as with O-link disorders of glycosylation. And then the third group are post-migrational. So these are often injuries after the neurons have reached their final point, and those are often vascular in etiology, and those can be polymicrogyria or schizencephaly. You also can have focal cortical dysplasias in this group as well, and that's one of the important delineations between the types of focal cortical dysplasias, because type 2 focal cortical dysplasias are abnormality in proliferation, whereas types 1 and 3 are abnormalities in post-migrational development. And so this is the most recent classification scheme by the ILAE in 2011, published in Epilepsy, where they broke them into 3 different types. Type 1 being abnormalities in post-migrational changes, type 2 involved with changes in proliferation, and the type 3 are post-migrational changes associated with a principal lesion, with focal cortical dysplasia type 3A associated with hippocampal sclerosis, type 2B associated with a glial or glioneuronal tumor, such as the DNETs that we saw in the past hour, or vascular changes with type 3C. And so walking through the types of cortical dysplasia, so type 1A is really the simplest to describe. On the right, you see the normal 6-layered neocortex, where just to the right of that, you appreciate the abnormalities with the type 1A, where you see abnormal radial cortical lamination with abundant microcolumnar organization. You have a significant number of these radially oriented neurons, more than 8 in a row, that disrupt the normal cortical lamination pattern. You have some increase in thickness of the cortex itself and some scattered neurons below in the white matter, but there is some retained organization there. Type 1B is abnormality along the tangential cortical lamination pattern with failure to establish the 6-layered cortex. You don't see the radial microcolumnar lines, but you see the clumps of neurons and often disruptions in the layers themselves. You can also have type 1C, which is a combination of abnormalities with radial and tangential lamination patterns. And together, these three types of, or these three parts of type 1 focal cortical dysplasias are often more diffuse and more difficult to isolate on imaging than type 2. Type 2A focal cortical dysplasias include all of the cortical dyslamination. So you see the radial microcolumnar orientation, you see the disruptions to the 6 layers, but you also have the addition of dysmorphic neurons. So if type 1 is an abnormality in architecture, type 2A is more of an abnormality in cytoarchitecture. The dysmorphic neurons are larger, they are often malrotated with abnormally distributed Nissl substance, and you have the accumulation of neurofilament proteins. Type 2B involves cortical dyslamination, dysmorphic neurons, but also involves the balloon cells that John had mentioned earlier that are more significantly enlarged with glassy eosinophilic cytoplasm and displaced nuclei. And oftentimes you see more significant abnormalities on MRI. So focusing on 2B, this can occur in isolation or it can occur in the setting of tuberous sclerosis or hemimegalencephaly. Type 2B focal cortical dysplasias have higher rates of drug-resistant epilepsy at earlier ages and higher rates of cognitive decline. And more commonly, they're associated with focal abnormalities on MRI, often a transmantle sign with blurring of the gray-white junction, cortical thickening, and bottom of the sulcus dysplasia. These balloon cells are the defining type for type 2B, and when they're involving cortical tubers and tuberous sclerosis, they're called giant cells. But as was mentioned in the last hour, these cells are quite immature. They actually stain positive for NeuN, which is a neuronal marker, and GFAP, which is a glial marker, indicating that they retain immaturity and a mixed lineage origin. They also stain positive for S6, which is downstream of the mTOR pathway and is involved in the overgrowth, and we'll be talking about that a little bit later.
I think having said what we've said about the array of neuropathologic and histopathologic distinctiveness, it's often, more often than we'd like to admit, probably clinically extraordinarily challenging, particularly in the pre-surgical stage, to figure out particularly what type we're dealing with. And again, that really is at the crux of the argument because it influences everything from surgical decision-making to our understanding about prognosis and outcomes. So we wanted to take the opportunity to present the case of a young lady who we both encountered close to 2 years ago at this point, who recently re-entered the children's system, and provide what we think is a representative example of how these patients often present, including some of the challenges inherent in figuring out the diagnosis, let alone figuring out how to proceed. This young lady first came to us at 12 months of age. She was healthy and developmentally totally normal up to that point. The family lives in Seattle, but was vacationing in Southern California at Disneyland. While taking a mid-afternoon nap, they observed upon awakening that she had abrupt behavioral arrest, unresponsiveness, and rightward deviation of her eyes that lasted roughly 30 seconds or so. They were a savvy family and identified that this was abnormal and likely to be a seizure straight away and sought medical attention. I will mention just briefly she was otherwise completely healthy, had never suffered from any of the typical seizure risk factors, meningitis, trauma, so on and so forth, was the only child of these two parents, but in the extended family nobody had epilepsy or any other type of neurologic issue. In California, she was hospitalized very briefly and started empirically on oxcarbazepine based on the clearly clinically focal nature of these seizures, and she had a couple of additional seizures at this time. But after this medication was started at a reasonable dose, remained seizure-free for 3 to 4 days, at least enough time for her family to travel back up here to Washington, but fairly quickly after had dramatic re-emergence of her seizures and was hospitalized elsewhere. Their continuous EEG monitoring showed seizures that indeed arose focally with a left occipital origin, and clinically these were associated with, at least in the awake state, what they classified as staring spells, as well as numerous nocturnal seizures that appeared to be subclinical in nature. She had, as I mentioned, dramatic escalation of the frequency and duration of her seizures, with most of these lasting several minutes, particularly the ones at night, and phenytoin was added with modest improvement. Clinical seizures did finally abate after loading and initiation of a maintenance dose of levetiracetam, and she was looking pretty good at that point prior to transferring care to us. Her workup very briefly, at least at this time, included the things that one typically expects with children who present in this way. So she had the EEG and MRI and some metabolic studies that aren't always part of our usual workup, but based on the dramatic, some would say explosive nature of her seizures and the frequency of them, that was felt to be on the list. Her EEG at our institution showed left occipital slowing, which we'll look at in a second, as well as frequent epileptiform discharges in sleep. She had a 1.5 Tesla MRI at this point, which again was 12 months of age, which was read at normal, as normal, and again we'll review that in greater detail. And broadly had screening for the more common inborn errors of metabolism, which was unrevealing, and she had of course had 2 of the typical newborn screens, which were normal as well. This is her awake EEG, which shows focal slowing, most prominent in the left occipital region, with otherwise pretty good preservation of normal features for age. When falling asleep, she has much more prominent and in many epochs nearly continuous epileptiform discharges in the same region, that left posterior occiput. She continued to make developmental strides, but was continuing to have occasional breakthrough seizures at the frequency of once every few days, often in brief clusters, and again, often associated with sleep or upon awakening. We optimized both of her anticonvulsant medications, which were the oxcarbazepine and the levetiracetam. But a couple of months later, based on persistent breakthrough seizures, zonisamide was added. After this agent was added to her regimen, she had roughly 2 months of seizure freedom, but then again broke through and began having up to several of these typical seizures per day, primarily nocturnal, with the new feature of this sort of turning pale. At this point, of course, with the occipital seizures, with the potential autonomic component to them, the idea of some of these syndromic occipital epilepsies did come up, Baniatopolis, Gastaut, occipital epilepsy, so on and so forth. But certainly the persistently focal nature of her seizures was concerning and a big clue that informed the rest of her workup. Seizures eventually became much more frequent and medically intractable based on our inability to control them with not 2 but 3 medications at good doses. And by 19 months of age, we initiated an epilepsy surgery workup, which we'll discuss with you next.
So she was admitted for phase 1 monitoring, and as we had seen previously, she has her most active EEG when she's asleep, and here she is asleep with, again, near continuous epileptiform discharges in the left posterior region. This was the onset of one of her seizures that shows a high amplitude slow wave, primarily originating from the left posterior region, followed by about 8 hertz activity in the O1 lead that eventually slows and leads to more monomorphic theta. Interestingly, she had no clinical manifestations during this. She was playing, she was active, although she's clearly using her left arm much better than her right arm in this picture. And hopefully this will work. So here you can see the fairly delta wave slowing that have fairly consistent spike and wave morphology in the O1 distribution. She's using that left arm quite well, but is not really either attending to the right, nor is she doing much to play on the right either. And then this is one of her seizures, where you see maximally at T7, P7, where she has high frequency discharges, and she loses tone. She has some automatic movements of her left arm, and again is not moving her right arm at all. But it's fairly hypomotor in etiology, and these can be fairly easy to miss for parents that are not as observant.
So, Jason,
Yeah.
was she, despite having the seizures, was she still meeting milestones?
She was really doing quite well.
Okay.
She had several words at that point, was running around, was very active. She had begun to have a little bit of a plateau, so by the time she was 18 months, I believe, but was not having any sort of regression. And we worried because she was already on 3, often 4 medications by that time. So on the day of her admission for phase 1, her seizures were so frequent that she essentially met criteria for non-convulsive focal status epilepticus. She was treated with multiple rescue medications and started on lacosamide with a rapid taper that broke her focal status, but did not completely eliminate her seizures, and she progressed along a pre-surgical workup with a repeat MRI and a PET scan. So this is her MRI at 20 months. And what you can appreciate is on the T1 sequence, she has nice gray-white delineation in the right occipital region. But on the left, you see some thickening of the cortex, some blurring of the gray-white junction, and then when you look on T2, you see some hyperintensities both over the gray matter and the white matter in the left lobe, or in the left occipital lobe compared to the right. Now, this didn't seem to involve only one gyrus. In fact, it seemed to involve much of the occipital lobe with potentially some posterior temporal lobe as well. And so she did have an MRI at 12 months that was read as normal. And at 20 months, it's clear that there was some asymmetry between the two sides. But at 12 months, in retrospect, you can appreciate how the two gyral patterns are somewhat asymmetric. There might be some more thickening in the left occipital, but you have such prominent terminal zones of myelination that often are hyper intense on T2, particularly in the occipital lobe, that it's often not until 18 months of age that you can really separate normal versus abnormal, which is why we always will repeat imaging after 18 months. So this was her PET scan, and this was an interictal study with showing significant hypometabolism, primarily in the occipital lobes, but also moving anteriorly into the posterior temporal. This is also prominent as you move up in the occipital, but it spares the parietal and the frontal cortices. So it is quite congruous with the MRI with this occipital focus. This is an fMRI study, and there's fMRI is fairly limited with what you can do under the age of 2. So this was a sedated passive finger tapping that allows you to model the sensory motor cortices. And what you can see is that there is normal sensory motor precentral gyral activation, both with the right and the left. So basically the left-sided sensory and motor cortexes are appropriate. You also can appreciate there is this foci in the occipital lobe of the left, which is likely her interictal spikes showing increased activation. And so in terms of surgical planning, she had a PET scan, an MRI, and an EEG, all consistent with the left posterior epileptic focus. So she certainly seems to be a good candidate for surgery. The question is, what kind of surgery do you do? Supporting a limited resection, her hippocampus was normal. There was no mesial temporal sclerosis. She has normal sensory motor activation, so certainly we want to be careful about doing anything involving the anterior parietal region with the possibility of affecting her motor and sensory function. And her visual evoked potentials did show mild asymmetry between the right and the left, but overall her function was quite normal, and she would be at risk for a significant field cut with a large resection. In support of a broader resection, though, the extent of her lesion is not clearly identifiable, and the epileptic zone and the epileptogenic zone might be much broader. At which point we'd like to bring up our expert to kind of describe what he might be talking to families about in this type of situation.
Fabulous. That's a great picture. I'm just going to turn that off now. Okay, great. So in Epilepsy Surgery Conference, basically the discussion comes down to risk and benefit, as you'd imagine. How certain are we that this patient is medically refractory epilepsy? Very certain. She's on 4 medications, still sees it frequently. How certain are we this is a structural epilepsy? Gosh, it really doesn't sound at all like Pankotopoulos syndrome, although it's kind of in the right age range. It doesn't sound at all like occipital epilepsy of Gastaut. It doesn't sound like any of the genetically acquired occipital epilepsies, in other words. And we have plenty of evidence pointing towards a structural lesion. Semiologically, is it concordant? Yeah, sure. So the eyes kind of tend to go to the right, the lesions on the left. You can make out of the posterior eye fields kind of whatever you want. They can go left, they can go right. So we can always make a case for occipital of epilepsy regardless of the side. Semiologically, it seems to be consistent with occipital epilepsy, although the nocturnal predominance, the hypomotor features make you concerned that there could be a frontal component, right? And so that's always a concern when we're facing these patients is, do we really know where the seizures are coming from? That would be an argument for a larger operation if you're not sure. We've done what we can do outside of invasive monitoring to make the case that they're coming from where we think they are. So it really comes down to how much risk are we willing to accept, and with the trade-off of the possibility of seizure freedom. So, in this case, the family was interested in a more tailored resection, which certainly made sense. In order to accomplish that, we would want to do electrocorticography intraoperatively in order to try and better define where the epileptogenic zone really is. So this is a fairly large area that seems to be abnormal structurally. So that's what we pursued.
Perfect.
Could I ask you a question?
Yes, sir, of course you can.
So how would you explain to the parents, or would you at all, the possible option of later on a second surgery if that looked like it might be necessary?
Yeah, that's a great question. So the question was, how would I explain to a family the possibility of a second surgery? And so in my discussion of the possibility of a more limited resection, which could theoretically include things like a laser ablation if there's a small enough area, I would say that there's always the possibility that if seizures recur or continue, that we could do another surgery, that doing so carries a slightly higher risk. Once you've violated the dura and there's scarring, there's a slightly higher risk, although certainly it's something that we frequently do. So I bring that up in the context of the pros and cons, discussing the pros and cons of a limited resection. Other questions for me? The announcement should have said Mr. Clinician, not Master Clinician. Mr. Clinician is my stage name.
So with that in mind, we actually did move to electrocorticography. So in terms of ECOG, Dr. Ojiman, the neurosurgeon, tested several areas and did several strips, including one on the left motor region, one on the left medial occipital, lateral occipital, and occipital pole. This was actually a second set of strips after he found there was really no epileptiform activity in either the parietal or temporal or frontal regions. And what he saw was that all of the epileptiform discharges arose fairly focally at the lateral occipital lobes over C15 and C16. And so he did have that discussion with the family about the potential risk of doing a limited resection, but specifically taking out this area. And so the decision was made to do a limited resection of the lateral occipital region. And so on post-operative imaging, you can see the area that was removed. Just the anterior occipital with some involvement of the posterior temporal, but quite small, with preserving likely her visual fields as well as much of her temporal lobes and motor and sensory function. The pathology returned as focal cortical dysplasia type 2A, which we'll talk about a little bit more.
Her success was short-lived. She did continue to make developmental progress and was actually, in terms of her diurnal seizures, evidently under good control, so much so that the zonisamide was weaned off fairly quickly. However, within probably the period of a couple of months, she developed what the parents were first describing as disrupted sleep with lots of nocturnal awakenings. Of course, this was attributed to all kinds of things. She's on several different anticonvulsants. She's an only child. She just got out of the hospital having had brain surgery. There were certainly lots of other reasons that she might be having disrupted sleep. But after lots of discussions, the parents ended up putting a camera in the room, which captured numerous arousals, some of which appeared to be just her sort of repositioning herself, but many of which appeared to be associated with eye deviation, limb shaking of the same kind of semiology that was associated with her earlier seizures. She was, of course, brought right back in for repeat long-term monitoring, and as you can see here, not a whole lot has changed. She continues to have focal abnormal slowing in the left posterior head region, associated with very frequent and in some epochs nearly continuous epileptiform discharges. This time she wasn't admitted in status, but certainly was nowhere near seizure-free, and in the 24 or so hours of recording, we captured roughly 20 or so seizures, almost exactly like this one, clearly with an onset right around 1, often associated with a foregoing slow wave followed by fast activity with subsequent evolution. Clinically, you can see she has an awakening out of N2 sleep. She has some stiffening, interestingly, initially of the left leg, but then begins to use that side more, some stiffening and clonic movements of the right leg, and potentially some automatic sort of thumb-sucking movements on the right. At this point, of course, we're exactly where we anticipated we might have been, where we have undergone a limited resection. We have, at this point, really minimal residual deficits, but certainly ongoing, very frequent seizures of the same semiology and localization that we have before. She's made it off one anticonvulsant, but is still on 3 others at this point. And so the question arose, and should arise, what to do next.
So certainly this was not the outcome that we would hope for. You hope that someone will become seizure-free following resection, or if not, that they'll become now amenable to medical treatment, neither which was the case for this patient, unfortunately. So fortunately, we had that conversation with the family, so they were ready for this. So now the question is, what should we do? So we can certainly try, or we can offer to the family a larger resection. What can we offer? Well, we can offer to basically take out the posterior aspect of the hemisphere, so-called Temporo-Parieto-Occipital, or TPO resection, right? Which would probably be the largest, so that'd be a motor-sparing procedure. But she certainly would lose vision, and the concern would be language, right? So there's a girl who is developing normally, has normal language to this point. How confident are we that she would be able to transfer language function to what seems to be likely her non-dominant side? Difficult to test language in a child this age. So that is certainly a risk, and that's something we have to discuss at length with the family. This, fortunately, is a child who does not have a more extensive dysplasia, so we have many patients whose dysplasias involve also the frontal lobe, and then the only other operation you could reasonably offer might be a hemispherectomy, right? So she has the possibility to do a motor-sparing procedure. And given how explosive the onset and the continuance of her epilepsy was, that's what was offered to the family, a Temporo-Parieto-Occipital Resection.
Question.
Sir?
So what do you think about that beautiful focal EEG showing the lateral occipital focus, and it just wasn't elsewhere, and it was just nifty and perfect, and
Yeah,
they took it out?
it was gorgeous.
So
Yeah.
What's going on?
Yeah, that's a great question. So I think what happened was that we were capturing part of the expression zone, but we really didn't capture the ictal onset zone, or it's possible that she has an extensive area of cortical abnormality and the ictal onset zone just migrated, and that can certainly happen. Procedure semiology didn't really change, so you'd imagine that, if the ictal onset zone shifted to an area that was nearby, that the expression zone didn't change. Right? That can certainly happen.
Could it have anything to do with the amount of time that was recorded? What was the length of time it was recorded?
Next question. So she had a phase 2 study, right? Yeah. So she had implanted subdural grid. So this was a long time. So she had days of recording.
Yeah.
Yes, sir.
A quick question going back to the functional MRI.
Yeah.
Does it seem there was maybe enhancement of that epileptogenic region in response to the finger tapping test?
Yeah.
Is there some thought that could be feeding into the circuit and causing enhanced activity or attenuation?
That's a really good question. That was kind of just above the thresholding, right? And did not seem to be a reliable finding per se. As you can see, there's lots of areas that come just above threshold, but don't kind of reach the level at which you'd expect for true motor involvement. She also had a resting state MRI that was done, and so the area that seemed to be abnormal in terms of cortical anatomy did not seem to be recruited into, say, motor networks or language networks. That's a really good question. Sir?
I gather she did have implanted grids.
She did. Yes, sir.
Was there a consideration of awake stimulation of the grid? Because the epileptic surround can be very stinky. Can be at some distance from an anatomically and electrophysiologically identified focus, because the focus, especially when you see it on the cortex, can be at some distance from the real focus, the one that stimulates the clinical seizures. Sometimes you have to hunt for those by stimulating the cortex and finding where at a distance from your putative focus you really stimulate the seizures. And that can lead to your tailoring the resection to be somewhat outside where you would have hunted first. And I wondered if that had been tried.
Next question. We did not do stimulation mapping for ictal onset. Stimulation mapping we tend to do for motor function, for example, or for language interruption, which we did not do in her. She's just too young to tolerate an awake procedure. We do it sometimes in teenagers or even older school-age children for that reason. She just wasn't of an age where we can wake her up in the OR and do it. Extraoperatively, we certainly can do stimulation mapping, but we just sometimes will incidentally provoke a seizure. What you can tell from that is that there's irritable cortex, but it can be hard to tell whether you're provoking a seizure that's their habitual seizure, or if you're provoking something just by directly stimulating the cortex around the area that's abnormal.
That can also give you a hint.
Mm-hmm. True, that's very true. So that was not done with her. Yes, sir.
Before this second procedure, is there any value in repeating the corticography to say what did we miss or where did we miss it, or can we correlate it to what we find pathologically?
That's a great question. Yeah. So the question would be, do you go back to say another phase 2? Do you do a phase 1 to make sure which was what was done, to make sure the seizures looked essentially the same on scalp recording? Then do you skip phase 2 and go straight on to resection, or do you do another phase 2? And for this child, I think another phase 2 would be what would be considered because of the uncertainty about the extent of the epileptogenic zone. That's a great question.
At least the tracings we see here look like they're just interictal discharges. But
Right.
I presume an actual seizure was recorded with
Yes.
ECOG and that was in the same location.
Yeah,
Mhm.
exactly right. Yeah, she produced quite a few, unfortunately. More fortunately.
So her second surgery, this was the TPO that Dr. Owens had discussed, where we had full removal of the temporal lobe as well as disconnection of the occipital lobe. And we got much more pathology from this with the much larger resection, and so I wanted to discuss some of the pictures. And these were pictures taken by Jessica Davis, who's one of the pediatric pathology fellows. So again, with the 6-layered control on the right, this is our patient with some preservation of the molecular layer, but otherwise completely dyslaminated cortex that is significantly thicker with neurons moving all the way down into the white matter, no clear gray-white delineation. You also have the microcolumnar layering vertically and numerous dysplastic neurons. This is a NeuN stain for neurons. Again, you're seeing the elongated cortex. You're seeing groups of neurons without any clear laminar pattern, and neurons extending all the way down into the white matter. Looking at it a little bit closer, you can see those neurons bunched up, often in a vertical pattern, and the axons are rotated in multiple different directions, so there's significant malrotation there. And then on the second set of pathology, we actually saw balloon cells. So we saw large cells with the glassy eosinophilic cytoplasm with displaced nuclei, along with the dysmorphic neurons that are the hallmark of type 2 focal cortical dysplasias. In terms of GFAP, which is a stain for astrocytes, you see numerous enlarged astrocytes consistent with reactive astrocytosis, and then on the right you see all of the staining of astrocytes because they have all of their end processes in place, and the areas of absent staining are really the neurons. But you also have these larger cells that are more significantly stained, and these are the balloon cells that both stain GFAP and NeuN. We looked at MAP2 dendritic staining, which is a microtubule-associated protein that we would expect to see nice linear distribution of the dendrites. But here you have neurons that are heavily stained with dendrites that are moving tangentially and against the normal longitudinal pattern. And then we also saw in the area next to her initial surgery a significant amount of inflammation, and this is months after the prior surgery. You see foamy macrophages, you see microglia as well as lymphocytes, a number of signs of chronic inflammation, which I think it goes to show the amount of time it takes the brain to really heal from a surgery such as this. And so based on the fact that we now saw balloon cells, this was revised from a type 2A to a type 2B focal cortical dysplasia.
We'll get back to her at the very end, but wanted to take the last just few minutes to discuss some of the prevailing ideas, theories, and controversies about what's going on in focal cortical dysplasia. So specifically, why do they appear to be different? Is it all just histopathologic? academic interest. Is there something more than that? Are they functionally different, and does it make a difference to patient outcomes? I think we spoiled that surprise at the beginning by saying, yes, it certainly does. And here's some of the thoughts as to why. There certainly are important differences between those FCDs now lumped into the FCD I basket and those lumped into the FCD II basket. Again, histopathologically, the important differences are in the type 2 FCDs, you have not only cortical laminar disorganization, but actual abnormalities of the neurons themselves, in addition to, in the case of type 2B, different cell types called balloon cells of presumably mixed lineage and potentially of functionally different significance. Certainly, when comparing patients with type 1 and type 2 focal cortical dysplasias, there are big differences in terms of what we typically expect on EEG. There's variability and spectrum to all of this, of course, but those patients with FCD type 1, which, as we've discussed, tend to be more broadly distributed, less easily recognized on MRI, less pathologically associated with abnormal clumps of nerve cells and more due to cortical laminar disorganization, are also harder to detect electrographically. It's not necessarily that there's a deeper focus, although that is certainly a question that should be raised, but more likely that there is a more distributed focus. It doesn't appear that the epileptogenic region, in air quotes, is any smaller. It is actually probably larger, but by virtue of its being more distributed, is harder to detect, at least on scalp recordings. There are a couple of fairly typical features seen in type 2 focal cortical dysplasias. These are, of course, what we've seen with the patient we just presented, these very frequent interictal spikes, polyspikes, and usually spike wave discharges, often associated with aftergoing a very fast epileptiform activity. Occasionally, these may be associated with abnormal slow morphologies, such as these delta brushes seen here, and there's all kinds of theories out there floating around about why these may be more likely to be associated with sleep onset. I think the jury is still out from that standpoint. We've talked a great deal about the radiographic differences between at least type 1 and type 2. I think certainly it's important to recognize that the majority of those focal cortical dysplasias detected radiographically are more likely to be type 2 simply because they're easier to see. That's starting to change as we begin to use more advanced imaging modalities, particularly as we begin to loop in other forms of complementary imaging, such as was discussed before, PET, as well as both ictal and interictal recording, along with imaging, plus novel post hoc imaging processing techniques from existing technologies. In other words, how can we use MRI to process those data differently and figure out what the human eye can't see. Very interestingly, there is evidence from multiple converging lines of research that these abnormal cell types present, at least in the type 2, and specifically in the type 2B pattern of focal cortical dysplasias, have important structural and functional linkages. Certainly, the abnormal features observed in type 2 focal cortical dysplasias, these dysmorphic neurons with these cytoarchitectural abnormalities, with radial dendrites directed really in any which way instead of at the apical surface, are very highly reminiscent of normal cortical neurons at 34 and 38 weeks of gestation, and in some cases just slightly earlier than that. Here we see large, fairly dysmorphic appearing neurons with enlarged, you can't see it here, but hypereosinophilic cytoplasm. Here in the 38-week category, we have a couple of neurons with these abnormally oriented apical dendrites. So structurally, they appear at least similar to these immature neurons, and as Jason presented earlier, and we'll talk about a little bit in just the next couple of minutes, there is immunohistochemical data to suggest that these neurons may have mixed, i.e. immature lineages as well. Functionally, they appear to be different also. Certainly we know from studies in young animals, other mammals, as well as humans, that supposedly set fundamental properties of the human brain seem to be different early on in development, and specifically the role of GABAergic receptors, particularly GABA-A receptors, seem to be fundamentally different. In contrast to their well-known inhibitory role in mature neurons, GABA, particularly through the action of GABA-A and its effects on the chloride gradient, appears to be an excitatory neurotransmitter early on. That, of course, has spurred all kinds of research in terms of modulating the GABA-A receptor in young babies, not all of which has been entirely fruitful. But certainly comparing these murine neurons at 4 and 17 days of postnatal life, the exogenous application of GABA produces a depolarizing in the young neuron as compared to hyperpolarizing, i.e. inhibitory response in the older, more mature neuron. Certainly this, at least theoretically, has implications for treatment modalities, which we'll talk about in just a couple of minutes, both in terms of drugs that we may want to try, but also importantly drugs that we may want to avoid. Also, there's been a fairly substantial body of work suggesting that through the excitatory actions of GABA, these abnormal malformations of cortical development, including focal cortical dysplasias, at least when they're electrographically active, may have a trophic effect. And it's thought that that, at least in some degree, is responsible for the epileptogenic recruitment of adjacent cortex. Clinically, the outcomes appear different between the various subtypes as well. Type 1 is more likely to be associated with a temporal locus as opposed to an extratemporal location for type 2A and 2B. In fact, in this compilation study of close to 300 surgical candidates, there were no temporal type 2Bs. Again, as we've heard earlier, a focal MRI is much more common, but still only about 50% of the time is that seen in the type 2 cortical dysplasias. However, despite all of that, and despite the fact that those with type 2, both A and B dysplasias, tend to have earlier onset of seizures, tend to have more frequent and incidentally more prolonged seizures, and may actually have a higher incidence of cognitive and other behavioral problems, probably related to their seizure frequency, these patients tend to do better. As we talked about earlier in the presentation, the rate of surgical cure, seizure freedom, approaches 50 to 60%, and at least in this conglomerate study, upwards of 70% in those patients with type 2B dysplasia. So I think it's important, therefore, to identify good surgical candidates and to have a robust algorithm for figuring out who is and who isn't appropriate for surgical management, but also what other alternatives we have. Certainly, there may be a role of novel imaging techniques as we are able to better pick these up earlier, as the epileptogenic process has had less time to recruit networks, recruit adjacent cortex. These patients may do better in the long run. I won't spend too much time on this except to say that there are plenty of post hoc image processing analysis platforms out there that can take basic, even T1 weighted MRI scans and do automated morphometric analyses of cortical thickness. This is gray matter intensity, and what's called a gradient, which is essentially a scalar difference between the gray and white matter, looking for blurring of the gray-white junction. Those can then be computationally combined mathematically to find areas that are undetectable to even the best trained human eye, and I would say that this area lined up very nicely in post-surgical outcomes, both with the electrographic studies as well as with pathology. Talking briefly about non-surgical options, anticonvulsants are something that I think needs to be looked into. The only randomized control, well, the only well-controlled trials that even approached randomized level of anticonvulsants in this population were all from surgical series. And the response rate, as one might expect in intractable epilepsy, is not quite a quarter. So it's important to note as well that this 1/4 of patients also seem to have a transient response and lost seizure control over time. There may be an exciting role of mTOR inhibitors, which Jason will talk about in a moment. And it's important to mention, albeit briefly, that other non-surgical interventions, such as the ketogenic diet and either implanted or non-invasive neurostimulation, such as vagal nerve stimulator, are at least as effective in these lesional cases as in their non-lesional counterparts. In other words, that roughly 50% of patients can expect a roughly 50% improvement in their seizure frequency. There is certainly a substantial minority of these patients, meaning those with focal cortical dysplasia, although those are usually those with multiple dysplasias, who will have a fairly substantial response rate, meaning seizure freedom or something like it, with the ketogenic diet. There are all kinds of theories as to why that may be the case. There's some new work suggesting that it attenuates DNA methylation in a lasting sense, leading to sustained changes in gene expression, and may also impact the mTOR pathway in an inhibitory sense.
So in the last few minutes, we had talked about how focal cortical dysplasia 2B is associated with activation of the mTOR pathway, and certainly our patient herself had enhanced phosphorylation of S6. And so what we see is that there are several genetic mutations that can upregulate the mTOR pathway, including many of the PIK3CA, the PI3K, which are involved with megalencephaly and capillary malformation. There's P10 with Cowden syndrome, and then of course neurofibromatosis and tuberous sclerosis. Other megalencephalies all lead to an upregulation of the mTOR pathway, leading to increased cell growth and protein synthesis. We think that even in many of these isolated cases, there are probably somatic mutations that act on this pathway as well. But there's some other evidence that it's not merely genetics that are causing some of these changes, that there might be perinatal infections that also can upregulate this pathway. There have been studies that show herpes viruses such as CMV, HSV1, and HHV6 have been identified in balloon cells and might be a trigger for increasing this pathway. There's also been some controversy about HPV16, which produces an oncoprotein E6, which has been detected in many cases of focal cortical dysplasia type 2B, but not other focal cortical dysplasia. So they propose that prenatal infection of HPV could actually trigger this pathway. Some more recent studies have looked for the DNA itself to see if it's there, and that has been lacking. But we do know that the E6 oncoprotein does activate AKT and increase mTOR down that pathway. And so certainly that is going to be an interesting area of study in the next few years. And we talk about mTOR as causing overgrowth, but it does not just cause overgrowth, it causes synaptic remodeling, increased neuronal excitability, and actually can trigger epileptogenicity. And so there's some question as to whether rapamycin not only can be effective in reducing the overgrowth, but also in reducing and altering some of these epileptogenic pathways. And I will sort of finish up on a recent study done down at Baylor looking at a P10 knockout mouse, P10 being one of the most upstream factors in the mTOR pathway. And what we see with the knockout mouse, and this is looking at the hippocampus, you see increased phospho S6 staining. You see increased astrocytic activation, looking at GFAP, and you also see increased microglial activation. And all of these are time dependent after the progressive epileptiform activity with age. So this is looking at needle EEG at 9 weeks in a wild type, and then at 4 weeks, 6 weeks, and 9 weeks. And we see progressive increase in the amount of epileptiform activity with time. And this 9-week time point is when you actually see most of the rise in inflammation. And then finally, rapamycin started at 9 weeks is actually effective in reducing the amount of time spent in epileptiform activity, significantly reducing number of spikes and reducing the motor seizures. It also prolongs the duration of lifespan in these animals as well. And there are currently some phase 2 studies looking at everolimus, not only in tuberous sclerosis, but in focal cortical dysplasias in general, to see if that can play a role in reducing the epilepsy. And so when we go back to our patient, she has a few things that are potentially favorable for her being seizure-free: her lesional findings on MRI, her type 2B pathology, which is favorable prognosis in terms of the surgical studies, focal onset of seizures, and she doesn't clearly fit a syndrome. But because we did not see that clear demarcation of flare abnormality, we don't know if we fully missed part of her frontal cortex that could also be abnormal. And certainly the early onset of seizures and her significant seizure burden puts her at risk for developmental issues. And so at 30 months of age, she was continuing to make developmental progress, but then she was having frequent nocturnal awakenings. Her parents continued to use the video monitor and captured her constantly waking up, so we brought her back for another long-term monitoring session. First, fortunately, all of these nocturnal arousals were non-epileptiform in nature. She's now on 2 anticonvulsants, but she is seizure-free and is making excellent progress in development. And this is her racing around the EEG lab. So thank you. Any questions? Yes.
So I think there are a couple of researchers in the children research establishment that are doing genetic studies of surgically removed.
Yeah, Bill
tissue
Dobbins
like this.
is doing that.
On her?
So I don't think not that I'm aware of, although usually he gets it at some point. But he's found a lot of these isolated malformations have some sort of abnormality in the PIK3CA pathway. I don't know if you have heard that. I haven't actually talked with him about this case.
I would say he hasn't got his hands on her brain tissue yet. There have been similar cases identifying a number of mutations upstream in the mTOR pathway. DEPDC5 seems to be a particular hotspot in a fair number of cases so far.
Is anybody think about using tumor paint at all in these animals or any other kids?
I don't know the answer to that question.
I was alerted by the outside viewers. They wanted to hear the question.
Oh, so yes.
The question from Dr. Lewis: has anybody thought of, or has anybody used tumor paint in identifying these lesions and improving their surgical resectability? And
I'm not aware of.
To our knowledge, no. I think one of the challenges is nobody really knows how tumor paint works. It's been isolated from scorpion venom. It does not appear to be membrane binding, and appears to bind independent of mitotic rate. These are obviously benign lesions, are slow growing, and it's not clear what biomarkers they might share with neoplasm. So I don't think we know the answer to that.
So some of the surgical outcomes you listed, I don't know, were those all in the era of MRI? Because I presume some of these individuals may have had temporal lobectomies not knowing what was being operated on, and then subsequently was found to have cortical dysplasia. So with the seizure-free rate, better or worse when you factor in that maybe we have
better imaging, right? So Dr. Ransom asks, now that we have better imaging, are the surgical rates better based on all of the studies? And certainly a lot of the meta-analyses go back fairly far, but most of the meta-analyses seem to go back to the, have been looking to the late 80s to early 90s, where it's primarily MRI, and they do try to attach the whether there was a complete resection versus an incomplete resection based on MRI. And they do show that having that complete resection is associated with a significant improvement in in seizure freedom.
And then I just have one other question. Why did you guys check POLD 1? Just because she had occipital onset seizures, or was there?
So
other features?
it was also due to the fact that we were racing. So Dr. Ransom asked, why did we do polymerase gamma looking for Alpers-Huttenlocher? And part of that was the fact that we were racing through anti-epileptics, and we were considering strongly about starting Depakote. And even though she didn't meet easy criteria for a mitochondrial disorder, we have been chastened to try to make sure that we don't miss them under the age of 2.
So this was a safety concern before you gave her valproate?
Sure.
So how often do you guys now send the epi chips before you do surgery? Like, I mean, this is frontal lobe, nocturnal frontal lobe epilepsy, all those things that you now, they do the gene chips.
Yeah, I would say
Also, Jim, I got other feedback from our remote viewers that they couldn't hear you well, so maybe you can approach the microphone.
So,
Just gonna do me a favor.
So Dr. Bloom asks, do we do epi chips before surgery?
And so, in cases where there's a clear structural lesion, then it becomes essentially not an issue, obviously. For cases where there's not a clear structural issue, which are the cases we most wrestle with, almost all of those patients have had a series of genetic studies sent, usually some targeted genes and then an epi chip, and then moving on to other things after that. So that's a great question.
Well, thanks, guys, for a great talk.